In this lecture, we'll be focusing on the gluteal region, an area of immense structural and clinical importance. As radiotherapy students, your understanding of this region goes beyond surface syndrome. The gluteal muscle. The gluteal muscles play a key role in posture, locomotion, and pelvic stability. They also serve as important landmarks in imaging, beam orientation, and therapeutic planning. The gluteal region houses major muscle groups, neurovascular bundles, and bone landmarks that influence both functional and clinical decision making. Whether you are evaluating soft tissue masses, planning immobilization, or interpreting cross-sectional imaging, a clear grasp of this anatomy is essential. Let's begin by identifying the major muscles of the gluteal region and exploring their attachments, functions, and relevance in radiological and therapeutic contexts. Now, let's break down the muscular architecture of the gluteal region. These muscles are organized into two functional layers, superficial and deep, each contributing to movement, posture, and joint stability. The superficial group includes the three gluteal muscles, gluteus maximus, medius, and minimus, and the tensor fascia lata laterally. These muscles are primarily responsible for hip extension, abduction, and maintaining pelvic alignment during gait. In radiotherapy, these muscles serve as key anatomical landmarks for beam orientation, especially when treating pelvic or sacral lesions. The deep groove consists of smaller muscles that act primarily as lateral rotators of thigh and the hip. These include piriformis, obturator internus, gemelli, and quadratus femoris. They also assist in stabilizing the hip joint, an important consideration when evaluating postural imbalance, nerve compression syndromes, or planning immobilization. Understanding the layered anatomy of gluteal region helps in interpreting cross-sectional imaging, identify soft tissue masses, and planning beam entry points with minimal disruption of functional muscle groups. It also aids in correlating symptoms like sciatica or gluteal pain with underlying anatomical structures, especially when evaluating piriform syndrome or post-traumatic changes. Next, we'll explore each muscle in detail, starting with gluteus maximus, its origin, insertion, function, and relevance in both imaging and clinical practice. Let's now focus on the gluteus maximus, the largest and one of the most powerful muscles in the human body. It plays a central role in hip extension, posture, and dynamic movements. The gluteal maximus is a powerful extensor of the thigh at the hip, especially active when rising from a squatting or seated position and during stair climbing or uphill walking. It also contributes to lateral rotation and stabilization of the hip joint, important for maintaining pelvic alignment and preventing collapse during gait. So, this is another important thing to consider. Gluteus medius and minimus plays a important role in pelvic steadying. So While the maximus drives extension, the gluteus medius and minimus are primarily abductors and medial rotators of the thigh. Their key function is to steady the pelvis over the supporting limb when the opposite limb is raised, so such as during walking. So when other leg is raised, we have to support for the steadiness. Weakness in these muscles can lead to a Trendelenburg gait, which is often visible in clinical imaging and gait analysis. These muscles serve as important landmarks in cross-sectional imaging and beam planning, especially when treating pelvic tumors, sacral region lesions, or evaluating post-surgical anatomy. Understanding their orientation and function helps correlate symptoms like gluteal pain, gait imbalance, or nerve compression with anatomical findings. Next, we'll explore the deep gluteal muscles, piriformis, obturator internus, and others, and their role in hip rotation, joint stability, and neurovascular relationships. Let's now revisit the gluteus maximus with a deeper anatomical lens, examine its origin, insertion, innervation, and functional significance. This muscle is not only powerful but also pivotal in maintaining upright posture and dynamic movements. The gluteus maximus originates from multiple points. The ilium posterior to the posterior gluteal line, the dorsal surface of the sacrum and coccyx, and the sacrotuberous ligament. These broad origins reflects its role in anchoring the posterior pelvis and contributing to hip extension. Most fibers insert into the iliotibial tract, which continues down to the lateral condyle of the tibia. Some deeper fibers insert directly onto the gluteal tuberosity of the femur. This dual insertion allows the muscle to influence both hip and knee mechanics. The gluteus maximus is innervated by the inferior gluteal nerve arising from the spinal roots L5 to S2. This nerve exists below the piriformis and is vulnerable during deep gluteal injections or posterior surgical approaches. Functionally, the gluteus maximus extends the flexed thigh at the hip and assists the lateral rotation. So it extends the flexed thigh at the hip and assists in lateral rotation. It also contributes to abduction and helps raise the trunk from a flexed position, such as rising from a chair or climbing stairs. Its role in stabilizing the pelvis and trunk is especially important during gait and weight-bearing activities. In imaging, the gluteus maximus serves as a key landmark for beam orientation and soft tissue contouring, particularly in pelvic, sacral, or proximal femoral treatments. Understanding its anatomical cause and innervation helps us to correlate symptoms like posterior hip pain, gait imbalance, or post-surgical changes with radiological finding. Okay, now turn our attention to the gluteus medius, a key muscle in the lateral hip compartment. Though less bulky than gluteus maximus, It plays a vital role in pelvic stability and lower limb control. The gluteus medius originates from the lateral surface of the ilium between the anterior and posterior gluteal lines. This broad origin allows it to span the upper lateral pelvis. It inserts onto the lateral surface of the greater trochanter of the femur. A prominent bony landmark, easily visualized in imaging and palpated clinically. The muscle is innervated by the superior gluteal nerve arisen from spinal root L4 to S1. This nerve exits the pelvis above the piriformis and supplies both gluteus medius and minimus, as well as the tensor fascia lata. Functionally, the gluteus medius abducts and medially rotates the hip, medially rotates the thigh at the hip. More importantly, it steadies the pelvis on the stance limb when the opposite limb is raised, such as during walking. Weakness or dysfunction leads to Trendelenburg gait, where the pelvis drops on unsupported side, often visible in clinical observation and gait analysis. In imaging, the gluteus medius serves as a lateral landmark for beam orientation and soft tissue contouring, especially in pelvic or proximal femoral treatments. So, understanding its anatomy helps correlate lateral hip pain, gait disturbances, and post-surgical changes with radiological findings. Next, we'll explore the gluteus minimus, its anatomical cause, functional role, and how it complements the medius in maintaining pelvic stability and hip control. Now, focus on the gluteus minimus, the smallest and deepest of gluteal muscles, yet vital for maintaining pelvic stability and coordinated hip movements. Anatomically, the gluteus minimus originates from the lateral surface of ilium, just beneath the origin of gluteus medius. It inserts onto the anterior surface of the greater trochanter of the femur. This anterior positioning allows it to contribute to the medial rotation of the thigh in addition to its primary role in abduction. The muscle is innervated by the superior gluteal nerve, which arises from the spinal roots L4 to S1. This nerve also supplies the gluteal medius and tensor fascia lata, forming a functional trio that stabilizes the pelvis during locomotion. Functionally, the gluteus minimus plays a critical role in steadying the pelvis when the opposite limb is raised, such as during walking or single leg stance. It works in tandem with the gluteus medius to prevent pelvic drop, a phenomenon clinically recognized as Trendelenburg gait when these muscles are weak or compromised. Let's continue our exploration of the tensor fascia lata or TFL. This slide offers a detailed lateral view of the thigh, showing how the TFL integrates with the surrounding muscles and The iliotibial tract, a key stabilizing structure for hip and knee. The TFL lies just anterior to gluteus medius and superior to vastus lateralis. It's closely associated with the iliotibial tract, a thickened band of fascia that runs down the lateral thigh to the tibia. So the TFL lies just anterior to the gluteus medius and superior to the vastus lateralis. It closely associated with the iliotibial tract, a thickened band of fascia that runs down the lateral thigh to the tibia. Both the TFL and the posterior fibers of the gluteal maximus insert into this tract, contributing to lateral stability during standing and movement. The TFL abducts and medially rotates the thigh at the hip. More importantly, it stabilizes the extended knee by placing tension on the iliotibial tract, especially when shifting weight from one limb to the other. This function is critical during walking, running, and maintaining upright posture. So, this maintain upright posture. It also helps prevent lateral knee collapse, supports pelvic alignment. In imaging, the TFL and iliotibial tract serves as lateral anatomical guides, especially when contouring soft tissue volumes or planning beam entry for pelvic or proximal femoral treatments. Understanding their anatomical cause helps correlate lateral thigh pain, iliotibial band syndrome, and postural imbalance with radiological findings. Next, we'll move deeper into gluteal region to examine the lateral rotators of the hip, piriformis, obturator internus, and the gemelli, highlighting their neurovascular relationships and relevance in both imaging and clinical practice. Let's now take a closer look at the TFL, or the tensor fasciae lata, a compact but functionally powerful muscle located on the lateral aspect of the thigh. Though small in size, its contribution to the hip and knee stability is substantial. The origin of the TFL is from the ASIS, ASI means anterior superior iliac spine, and the anterior part of the iliac crest. From this origin, it descends vertically and blends into the iliotibial tract, a thickened band of fascia that runs along the lateral thigh. Its insertion is at the lateral condyle of tibia via iliotibial tract. This long fascial connection allows the TFL to influence both hip and knee mechanics, acting as a dynamic stabilizer during movement. The muscle is innervated by the superior gluteal nerve, which is arising from spinal roots L4 to L5. This nerve also supplies the gluteal medius and minimus, forming a coordinated group that governs lateral hip control. Functionally, the TFL abducts and medially rotates the thigh at the hip and also contributes to hip flexion. Importantly, it helps keep the knee extended by placing tension on the iliotibial tract especially during standing, walking, or shifting weight from one limb to other. So now that we have explored the superficial gluteal muscles, let's move deeper into the anatomy of the posterior hip and upper thigh. This dissection reveals the intricate network of deep muscles, nerves, and vessels that lie beneath the gluteus maximus and medius. At the center of this deep layer is the piriformis muscle, which exits the pelvis through the greater sciatic foramen. It, it serves as key anatomical landmark. Above it runs the superior gluteal nerve and artery, and it below it the inferior gluteal nerve and artery along with the sciatic nerve. This relationship is critical in both imaging and clinical practice, especially when evaluating piriformis syndrome or planning posterior approaches to the hip. Surrounding the piriformis are the short lateral rotators of the hip. What are those? Superior and inferior gemellus muscle, obturator internus, quadratus femoris. These muscles originate from the ischium and surrounding pelvic surfaces and insert into greater trochanter or intertrochanteric region of the femur. Their primary function is to laterally rotate the thigh and stabilize the femoral head within the acetabulum, especially during dynamic movements. From a radiotherapy perspective, these deep muscles and their associated neurovascular bundles are essential landmarks. They help us define soft tissue planes, guide beam orientation, and inform contouring decisions, particularly when treating pelvic tumors, sciatic neuropathies, or post-surgical reconstruction. Also visible in this dissection are the sacrotuberous ligament, ischial tuberosity, and proximal hamstring organs, structures that contribute to pelvic stability and are often involved in trauma and degenerative conditions. Let's now examine the gemelli muscle, a pair of short, deep muscles that flank the obturator internus and contribute to the lateral rotator group of the hip. Though small, they play a vital role in stabilizing the femoral head and controlling rotational movements at the hip joint. The, the superior gemellus originates from the ischial spine, while the inferior gemellus arises from the ischial tuberosity. Both muscles insert onto the medial surface of the greater trochanter of the femur alongside the tendon of the obturator internus. Their innervation reflects their anatomical neighbors. The superior gemellus supplied by the nerves to obturator internus, the inferior gemellus supplied by the nerve to quadratus femoris, both branches of the sacral plexus. Functionally, the gemelli muscles laterally rotate the extended thigh at the hip and abduct the flexed thigh. More importantly, they help steady the femoral head within the acetabulum, especially during dynamic movements like walking, climbing, or shifting weight. From a radiotherapy perspective, these muscles are part of the deep gluteal compartment, and their anatomical positioning is crucial when evaluating sciatic nerve pathways, soft tissue masses, or post-surgical reconstruction. Their proximity to the sciatic nerve also makes them relevant in cases of deep gluteal syndrome or piriformis-like presentations. In imaging, the gemelli muscles serves as deep reference point for contouring and beam orientation, especially in axial and coronal views of the pelvis and proximal femur. In summary, the gemelli muscles may be small, but their contribution to hip stability, rotational control, and clinical imaging is significant. A clear understanding of their anatomy enhances both diagnostic precision and therapeutic planning. Let's now turn our attention to the obturator internus, a deep fan-shaped muscle that plays a central role in lateral rotation and stabilization of the hip joint. Anatomically, the origin of obturator internus is from the pelvic surface of the obturator membrane and surrounding bony margins of the obturator foramen. This broad origin within the pelvis allows the muscles to funnel through the lesser sciatic foramen, making a sharp turn before inserting into the medial surface of the greater trochanter of the femur. So it makes a sharp turn before inserting into the medial surface of the greater trochanter of the femur. It is innervated by the nerve to obturator internus, which is arising from spinal root L5 to S2. This nerve also supplies the superior gemellus, forming a functional unit that support hip stability and rotational control. Functionally, the obturator internus laterally rotates the extended thigh at the hip and abducts flexed thigh. More importantly, it helps steady the femoral head within the acetabulum, especially during dynamic movements like walking, pivoting, or shifting weight. From a radiotherapy perspective, the obturator internus is a key anatomical landmark in pelvic imaging and beam planning. Its proximity to the obturator canal, internal pelvic wall, and sciatic nerve makes it relevant when evaluating soft tissue masses, nerve entrapments, or post-surgical reconstructions. In axial CT or MRI, the obturator internus appears as a distinct structure hugging the lateral pelvic wall, often used to define treatment fields or assess muscular integrity in trauma and tumor cases. In summary, the obturator internus is more than just a lateral rotator. It's a pelvic stabilizer, a clinical landmark, and a radiological guide. A clear understanding of its anatomy enhances both diagnostic precision and therapeutic planning. Let's now complete our tour of the deep lateral rotators of the hip with the quadratus femoris, a short, flat muscle that lies just inferior to the gemelli group and obturator internus. Though compact, it's a key role in stabilizing the hip and controlling rotational movements. The origin of quadratus femoris is from the lateral border of the axial tuberosity, a prominent bony landmark of the pelvis. From there, it travels laterally to insert onto the quadrator tubercle on the intertrochanteric crest of the femur, just posterior to the greater trochanter. It is innervated by the nerve to quadratus femoris arising from the spinal roots L4 to S1. This nerve also supplies the inferior gemellus, forming a functional unit that supports hip joint integrity. Functionally, the quadratus femoris is a strong lateral rotator of the thigh at the hip, and it also contributes to abduction. More importantly, it helps stabilize the femoral head within the acetabulum, particularly during weight-bearing and dynamic movements. From a radiotherapy standpoint, the quadratus femoris is a deep posterior landmark, important when evaluating sciatic nerve pathways, soft tissue tumors, or post-traumatic changes in the hip region. Its proximity to the ischial tuberosity and sciatic nerve makes it relevant in cases of deep gluteal syndrome or posterior hip pain. In axial imaging, it appears a dense rectangular muscle bridging the pelvis and femur. So it appears as a dense rectangular muscle bridging the pelvis and femur, often used to define the posterior boundary of the hip joint and guide beam orientation in pelvic treatments. In summary, the quadratus femoris may be most posterior of the lateral rotators, but its contribution to hip stability, rotational control, and imaging clarity is essential. A precise understanding of its anatomy enhances both diagnostic accuracy and therapeutic planning. So now we have completed the muscle groups around the gluteus.